Bring the microphone up. Thank you. I wasn't sure what this was. It was like a wave. Okay, can you hear me now? Okay, now I'm auditioning for an AT&T commercial. Okay, so welcome to the Miracle of Living event for this evening, and I think we have a great panel for you guys to discuss cancer prevention and early detection. My name is Zachary Gray. I am an emergency physician. I've been here at Torrance for a little over 20 years, and I am moving into a different role at the hospital and am the incoming chief medical officer starting in the beginning of the year, and they asked me to introduce this distinguished panel of guests. Thank you. The panel, I guess I'll start out in no particular order. Dr. Neil Bhayani, who is a general surgeon and the director of both the liver, pancreatic, and complex cancer surgery program and reflux and esophageal surgery at the Association of South Bay Surgeons. And in addition, he is the chair of our liver, pancreatic, and gastrointestinal cancer program here at Torrance Memorial. He has a busy practice focusing on major abdominal cancer, gastric, and esophageal surgeries, and also focuses on minimally invasive techniques. He did additional training and fellowship in general surgery involving pancreatic, liver, stomach, and esophageal surgery. Next panelist is Dr. John Abe, who is a board-certified internist, pulmonologist, and critical care specialist. He completed his medical degree at Hahnemann University in Philadelphia, and then residency and his pulmonary critical care fellowship at Harbor UCLA Medical Center. He is part of the teaching faculty at Harbor UCLA and is the co-medical director of our intensive care units here at Torrance Memorial. And we also have Leena Tran, who is a cancer genetic counselor at Cedars-Sinai, who completed her training with a Master's of Science in Human Genetics and Genetic Counseling from Stanford University after completing a microbiology, immunology, and molecular genetics degree at UCLA. And she is passionate both about provider and patient education, as well as improving healthcare access and outcomes for patients of diverse backgrounds. And finally, last but not least, we have Marissa Minderler, is that better? I apologize. She is a registered dietitian who is driven by her motivation to educate and assist people in reaching their health and wellness goals. She graduated from USC with degrees in both kinesiology and a master's degree in nutrition, and has always had an interest in nutrition, weight management, fitness, and performance, in addition to women's health. She's also a published author with journal articles on the topics such as polycystic ovarian syndrome. And with that, I will go ahead and turn it over to Dr. Bhayani, I think, who will start off the presentation.
Thanks so much, Zach. I wanted to first of all thank you guys for coming on a rainy day in Southern California, which we can't say happens all that often and maybe should happen more, but thank you all for coming out. I was asked to sort of speak about abdominal cancers in general, which of course is a huge topic, so I'm so glad we were able to focus in on colon cancer. I'm sure many of you guys walked in through the giant inflatable colon, which is sort of an interesting trip, metaphorically speaking, as long as we're going in the right direction. So colorectal cancer is somewhere between the second and third most common cancer diagnosed in the United States, and it is either the second or the third most leading common cancer death, depending on which year you're looking at it. It kind of bounces around. Most of it is in older people, but there are some, a significant portion, the less than 10%, that are in people younger than the age of 50. So what is colon cancer? When we talk about colon cancer, we're talking about something that starts with the inside, the lining of the colon. Now, the normal lining of the colon, as you see in the picture and what we walked through on the way in, should be relatively smooth and shiny. And there are 3 to 4 parts of the colon, depending on how you look at it. But most colon cancers don't have symptoms, and this is where some people get hung up. A lot of people expect to feel ill when they're ill. And cancer, regardless of really which kind, really does not present until you have significant delays in care and a very, very advanced cancer. And I think that's absolutely critically important as we're talking about prevention and detection and surveillance, as this is something that you can only find if you go looking for it. If you wait for it to show up, you're behind the ball. So that's why screening is so important, because if you go looking for it, not only can you find it, but you can find it early and cure it most of the time. Early cancer treatment, whether it's endoscopic polypectomy through a colonoscopy or surgically, can reduce your chance of death by over 90%. Cure rates for early colon cancer are over 95%. So the warning signs, the other end, if you're not, no pun intended by the way, if you are not getting screened, what might you notice from a colon cancer? You might notice blood in your stool, whether it's red blood or dark blood, or tarry or sticky stools. Your stools might start to change in size and shape because there's really no room for the stool to come out. You may get cramping or bloating, constipation, and certainly weight loss or loss of energy is really kind of the advanced stages. At this point, you're really in trouble. So it may be something as simple as a polyp, a precancerous item, or an early cancer that can just be removed by snipping it off right here through a colonoscopy. Or maybe it's something a little bit more challenging where there isn't an easy way to remove it endoscopically. Or maybe it's really something so big that it's causing a major problem by causing a blockage. You can imagine it's very difficult for stool to pass through when there's a tumor like that growing in there. Prevention. I wish I could tell you that IV vitamin C or some of the things that we read or hear on YouTube or TikTok or Facebook are actually worth anything. But despite billions of dollars of studying things that prevent cancer, we really have come down to some very basic items. First and foremost, to be honest, is a very healthy lifestyle. So tobacco cessation, making sure that you're not overweight. These are two of the biggest things that you can do to reduce your risk of colon and rectal cancer. There have been excellent studies on both aspirin and vitamin D. If you're looking for a supplement to reduce your risk of colon cancer, those are your two go-to things. These have to be pretty high doses of vitamin D. It's not just drinking a glass of milk every night. Okay, so you need to be on a vitamin D supplement. Plant-based diet. So this is somewhat controversial, obviously, because people don't want to hear it. We love our meat in this country. We do. We have a very, very protein-heavy diet, much more so than our kidneys need and much more so than our colons appreciate. But whether you are meat light or you are plant-based, either way, this drastically reduces your risk of colon cancer. Now you could make the argument, oh, well, it's all about processed meats. That's true. Processed meats are the worst for you. Absolutely, whether you're eating Spam or smoked this, that, and the other, okay? Smoked and salted meats really are even worse for you. But a diet heavy in protein, animal proteins, red meat, pork particularly, also has been shown to increase risk of cancer, particularly colon cancer. So if you can't prevent it, how do we watch out for it? How do we find it early? Well, everyone loves this. This is easy. Put a little stool on a card, a fecal occult blood test. You can do it in your doctor's office. They sent you a card. It's very easy. I think we're handing them out today. And if not, this is the easiest way to do it. The thing is, it's not particularly accurate. At a minimum, if you're going to do it, you need to do 3 cards every year if you're going to watch out for this. So helpful, easy, but not particularly accurate. Next up would be stool testing. Those people have heard of FIT testing and Cologuard. Those are the 2 major things looking to find cancer DNA in the stool. Now I'm going to say that again. Cancer DNA or cancer cells in the stool. The point I'm making there is it's too late. It's too late if you're finding cancer in the stool. then you've missed the boat. You already have cancer. The whole goal of screening, at least in my opinion, is to prevent you from having cancer. CT colonographies, there's a special CT scan that you can get, which does require a bowel prep, cleaning out your colon, a colon cleanse, okay, to help you find a polyp, all right? And then, of course, there's colonoscopy. And where I'm going with this is hands down your best test. It is the most accurate. It's how you get the polyp out, and you're finding polyps, which are precancerous. You're not finding cancer, hopefully. If you're doing it often enough and if you're doing it properly, then you're finding polyps, and you'll never find a cancer because they're taken out before you even turn into cancer. So this fit testing, I wanted the most accurate stuff, so I pulled this off of Amazon last night. Anyone can get it. The second generation, because I don't know when the first generation was, but the second generation's got to be better, right? You can get it for the bargain basement price of $32 shipped to your door in 2 days, if you're in a hurry, okay? So if anybody's feeling so inclined, you can go and get, and the results are instantaneous. This is looking for DNA in your stool, and sometimes hemoglobin in your stool, blood. At this point, yes, you may find an early polyp or an early cancer or something precancerous, but most of the time, what you're finding with this test is a cancer. It's already too late. So even if you have cancer, this test is going to miss it approximately 26% of the time. And that data is from the manufacturer, so you know that's as the best number they could possibly get out there. So in real life, we all know that things are not, you don't get the same mileage they put on the sticker when you drive off the dealer, right? So it's kind of the same thing. Here's the other nasty little secret. 15% of these tests, when they're done, are positive. Most of those positives are actually negative. So you get a positive fecal immunotesting, and then you have to go get a colonoscopy, and most of the time that colonoscopy is negative. There's nothing there. So you're missing cancer, and you're doing a lot of extra stuff you don't necessarily need to, and you're not finding precancerous things, all right? So Cologuard, yes, it's more accurate. They're actually looking for DNA, but again, you still have a significant number of people that have a false positive. The test is positive, but there's nothing actually there, and the only way to prove it once you get a positive is, of course, a colonoscopy. So you can see on all these slides that all, no matter what you do, all directions, all roads lead to a colonoscopy, right? A virtual colonoscopy, again, is a CT scan. There's radiation involved. You can't be doing this every year. You'll start to glow in the dark. It's certainly not as accurate as a colonoscopy, and you can miss precancerous or smaller polyps. By the way, you still have to do the terrible prep the day before. The terrible prep. This is the worst part of the colonoscopy for anyone who's ever had it, and you have to do it more frequently. And oh, by the way, guess what? The moment you find something, call your GI doctor because you need a colonoscopy. Okay? All right. So this is the scope. I was tempted to put a picture of a toilet right next to it, because the scope actually isn't the worst part. For anyone who's ever had a colonoscopy, everybody knows the worst part is the day before and that awful stuff they make you drink and the amount of liquid that you need to drink so that you don't feel absolutely dehydrated and parched, and the fact that you're running to the toilet pretty much all night long. But this is what everyone thinks about when they think about a colonoscopy. This is the actual scope they put up to take a look around. Sigmoidoscopy. So this is what Kaiser does. Okay? Kaiser gets a nurse practitioner to take a short scope under slight sedation up through about here, the sigmoid colon. So they're looking at about a third of the colon. Now it works. You can find cancer from here to here, but you're missing the rest of it. So most of the rest of the country doesn't do this except for Kaiser. Okay? Colonoscopy. This is the gold standard. If I haven't pitched it enough yet, I'm going to pitch it again. Go get your colonoscopies. This is the absolute gold standard. You find precancerous polyps, you find early cancer, you take them out, and you get the diagnosis for sure, okay? And you find this in a lot of people. Believe it or not, colon cancer, by the way, is more common in men. So this is what it looks like. They go in there and they find a polyp, and in this case, it's got what we call a stalk, kind of like a flower or a dandelion, and they take a device, which is like a lasso, loop it over, and just snip it off. And then we send it to the lab, and our wonderful pathologists look at it under the microscope and tell us what it is. Regardless of what it is, you no longer have to worry about it because it's not inside anymore. So all these major organizations, and this is where I'm going to end, all these major organizations, whether it's a government body or professional societies, everyone agrees that colonoscopy is the 100% best way to both to find and properly, accurately screen for colon cancer and rectal cancers. And that's where we should focus our attention. And I just wanted to thank you all for coming out on a rainy night and hearing me pitch the colonoscopy. By the way, I don't do them. That's all for the GI guys.
Thank you, Dr. Bhayani. I think we'll go ahead and progress. Are we going to take questions first, Mary, or are we going to, I don't even know where you are. Okay, so we'll go ahead and move on to Dr. Abe, who's going to talk to us about lung cancer screening.
All right, hi everyone, thanks for coming. So I'm going to talk about lung cancer, and I'm going to first of all give a brief overview of lung cancer and then talk about two particular aspects of lung cancer, namely lung cancer screening with low-dose chest CT scans, and then also this new robotic bronchoscopy platform that we've had since the beginning of the year that has helped us to diagnose early-stage lung cancers. So first of all, why should we care about lung cancer? And the bottom line is that lung cancer is the leading cause of cancer death, not only in the United States, but in the entire world. It's estimated that this year about 155,000 people will die from lung cancer in the United States. And to put that number in perspective, I like to compare it to the number of people who die from other cancers. If you look at the number of people who die from breast cancer, colon cancer, and prostate cancer every year, more people die from lung cancer than from those three other cancers. So it's a huge impact, and a lot of people don't know this because I don't think lung cancer gets a lot of press for a whole variety of reasons. But a lot of people don't know, for instance, that 3 to 4 times as many people die from lung cancer than breast cancer. Briefly, just to go over the risk factors, the point I want to make is that I think we all know that tobacco smoke is the main risk factor. Cigarette smoke is the leading factor, with pipe and cigar smoking being a little less of a factor. But what I think a lot of people don't know is that up to 20% of people who are diagnosed with lung cancer have never smoked, ever. And this is a particular problem for women more than men. The good news is that the incidence or the rates of smoking in the United States have gone down quite a bit. So if you go back to the 1960s, over 40% of adult Americans were smoking. Now we're down to about, we're down to just about 11% here. But I'm glad that that's a big drop in the incidence of smoking. There still is about 28 million people in this country who are smoking. So that's still a substantial number of people that are smoking. And even if everybody were to quit smoking today, lung cancer would still be a problem going forward because the risk of developing lung cancer even after you stop smoking persists for many years. So briefly want to talk about symptoms. I like to divide symptoms into local symptoms from the chest and symptoms that occur once the cancer has spread. When a cancer is in the lungs, it can induce a cough. It irritates the airways. If the tumor is big enough, it could bleed, and then you cough up blood. We call that hemoptysis. If the tumor is occluding an airway, it can cause a person to be short of breath. And if it invades into the chest wall, it can cause pain in the chest. And lastly, it can also cause hoarseness because there's a nerve called the recurrent laryngeal nerve, which travels from your neck into your chest and then back up to your vocal cords. If a tumor is impinging on that, it can cause the vocal cords to become paralyzed and a person can become hoarse. Extrathoracic symptoms, so if the tumor has spread outside the chest, let's say it's spread to the bones, then you can have pain in the bones. If it's spread to your brain, you can have neurologic symptoms. And if the tumor is large enough, it can cause systemic symptoms such as weight loss, loss of appetite, and fatigue. This is an example of someone who presented to our ER 2 months ago with symptomatic lung cancer. And, oops. This tumor here, you can see, it's pretty obvious. A very large tumor in the left lower lobe. This is a PET scan. I'm not sure if you're familiar with PET scans, but PET scans will light up in areas where there's cancer. And you can see this black area here is all cancer. And these areas are conglomerates of lymph nodes that the tumor has spread to. And you can see a lymph node in the neck and lymph nodes in the upper abdomen as well. The point I'm trying to make is that by the time you've presented with symptoms from lung cancer, you already have advanced lung cancer. So you have cancer that has spread to the point or grown to the point where your chances of survival are very low. So these two CTs are actually from people that I took care of who had screening CTs and were found to have lung cancer based on those screening CTs. You can see that this small tumor here, which probably measures only about 11 by 8 millimeters, that's a stage 1 cancer. And then this one here, which is about 9 millimeters, again, a stage 1 cancer. These people had absolutely no symptoms, and the only reason we found it was because they had screening CTs. Another way of looking at this chart shows 5-year survival based on stage. So this line up here is the stage 1A1, 92% survival at 5 years. By the time you get down here to stage 4 lung cancer, it's almost 0% survival at 5 years. And then these are all the different stages in between. So you can clearly see as your stage advances, your chances of survival decreases. So just to give a brief history of what we've tried to do with lung cancer screening, back in the 60s, 70s, and even going into the 80s, we looked at chest x-rays. Why not? Can we find cancers on chest x-rays? Well, here's a cancer that was identified on a chest x-ray. But again, by the time you can see it on an x-ray, it's already pretty advanced, at the very least locally advanced. So none of these studies, and there were many, many of them, thousands and tens of thousands of patients that we looked at, basically chest x-rays, they always failed. They were never found to have a benefit in screening. Sputum cytology we also did, where people would cough up sputum, we would send it to the lab, look for cancer cells. We did that in the 60s and 70s, that also failed. And it wasn't until we started using low-dose CTs to screen that we found that there was a benefit. So this was the study that put lung cancer screening on the map. It's called the National Lung Screening Trial. It took place here in the United States, and it was published in the New England Journal of Medicine in 2011. And because the results were positive, it led to Medicare approving low-dose screening CT scans here in the United States in 2013. Briefly want to go over the way the trial was designed. There were over 50,000 participants, so this was a very, very large trial. They looked at people who were aged 55 to 74. They had at least a 30-pack year history of smoking or more, which means that they smoked 1 pack of cigarettes per day, every day for 30 years. So quite a bit of smoking. And you also had to be either a current smoker or had quit within 15 years. 60% or so were male, 40% were female. And what they did is they randomized the two people, or the two, there were 2 arms, and you were either randomized to getting a CT scan every year or a chest X-ray every year. And they followed people with these images for 2 years, and then for 4.5 years after that, continued to follow them to see if they developed lung cancer. So these are the results. There was a 20% reduction in lung cancer mortality with only 2 years of screening. Okay, so 20% may not sound like that much. It's not the same as the 90% that you get with colon cancer, but you have to realize that they did a CT here when they enrolled, they did a CT at year 1, and they did a CT at year 2. After that, there were no more CTs. So you can imagine that if they continued doing yearly CT scans, which is what we now do in actual practice, that these 2 curves would separate even more than they are showing right now. And we do know that the benefit, this 20% benefit, is really a floor. It's the minimum amount of benefit. There have been other trials since the NLST which have proven more benefit, but even those trials had some limitations. So we do believe that the actual reduction in lung cancer, if properly performed, is much, much higher than this. What they did find is that 70% of the cancers that they found in the CT group were stage 1 or stage 2 cancers. So exactly what we wanted to find, these early stage cancers. What they considered to be a positive test was a nodule which is only 4 millimeters or more. And about 1/4 of people were found to have nodules of that size or larger. But we know that when we do CT scans, we're going to find these small nodules, and the great majority of the time they're benign. And they actually show that about 97, 96% of those nodules were benign. So what are the potential harms? There is radiation, okay, but the amount of radiation is pretty low. The units of radiation, they're measured in what we call millisieverts. And just to give you an idea of what a millisievert is, the amount of radiation that we all get just by living here in the South Bay every year, we'll get about 2 to 3 millisieverts. With a low-dose CT, you're getting about 1.5. So about half a year's worth of radiation just living here in Southern California. If you compare it to X-rays, you're getting about 15 times as much as you would get with a chest X-ray. You're getting about a little over twice as much as you would get with a mammogram. So while there is radiation, we're not going to glow in the dark. And while we have to be cognizant of the radiation risks, the benefits vastly outweigh the risks. Now, there's also the issue of patient distress. When we started doing lung cancer screening, there were so many articles and editorials about how patients might become distressed by the fact that we found these nodules. I can tell you, after 10 years of practice and doing this, I would say that nobody gets distressed. In fact, it's almost the opposite. People are reassured. When I say, Mr. Smith, we found on your screening CT a 5 millimeter nodule, I'm 99% sure it's benign, but you know what? We're going to get a CT in a year, and we'll keep an eye on it. And they feel better. They know that we're keeping an eye on things. I would say 1 or 2 patients in the last 10 years had some anxiety, but it really isn't a big factor. Now, complications from procedures, okay? So if we do find a larger nodule that does look suspicious for cancer, we are going to try to biopsy it. And yes, there can be potential complications from any biopsy, but the NLST showed that the complication rate from these procedures was very low. The last thing I want to talk about is overdiagnosis, which is a concept, it's a little bit hard to wrap your head around, but it's basically the thought that you're going to diagnose a cancer that a person's going to die with and not from. And when they delved into this after the NLST, they really found that only about 1% of cancers fell into that category. So these are the current guidelines. So the age range has been extended because remember the NLST looked at people age 54 to 75. Now it's 50 to 77 based on a trial that was conducted in Europe and came out in 2019 that looked at people in this age range and found a 30% improvement in survival. The amount of pack years also went down to 20 pack years, down from 30, again because of that Nelson trial from 2019 where they had people who only had a 20 pack year history of smoking. So these are the Medicare guidelines on the left. The U.S. Preventive Services Task Force came out with their own guidelines, which usually Medicare follows. They've extended that range all the way up to 80. And in fact, there are many different societies, medical societies, that actually recommend screening even after 80, as long as you fulfill these other criteria, and if you are fit enough and well enough to undergo treatment if you were found to have cancer. So ideally, what do we want? We want people who are eligible to get screened. If they're found to have a suspicious lung nodule, be referred to a person, usually a pulmonologist, and then have a diagnostic test performed. The main tests that we've been doing for many, many years are CT-guided needle biopsies, surgery, or bronchoscopy. And this is a CT of a person getting a CT-guided biopsy. You can see the needle going through the chest wall, through the surface of the lung, and into this tumor. We can get a diagnosis this way, but when you go through the surface of the lung with a needle, you're going to put a hole in it. And that hole can cause air to leak out. We call that a pneumothorax. And if a significant amount of air leaks out, it compresses the lung, causes the person to have problems breathing, and a tube has to be put in the chest to suck the air out. That person has to be admitted to the hospital, and that tube has to stay in place, sucking that air out until that hole seals on its own. And that can take anywhere from 2 to 4 to 5 days or sometimes more. Surgery, we can do surgery, and I've certainly sent many people to the OR, to my thoracic surgery colleagues, to have a surgical biopsy because I didn't know what it was. I couldn't get a biopsy in any other way, and I was suspicious that it was cancer. But the thing is, sometimes it's not cancer. Now you've put a person through a major operation, and there's no cancer. The last thing we use is bronchoscopy, and I'll talk a little bit about that on the next slide. So the robotic bronchoscopy platform that we have now is much better than what we've had in the past. First of all, when we do a biopsy from a bronchoscopy, we're biopsying from the inside of the lung. So the risk of us puncturing through the surface of the lung with our instruments is much lower. It's not zero. If there's a nodule that's right here on the surface of the lung, we may accidentally puncture through the surface of the lung and cause a pneumothorax. But the rate or the incidence of pneumothorax is certainly much lower. The other advantage is if a person has more than one nodule, and certainly we see people who have suspicious nodules, 2, sometimes even 3, we can biopsy all of them, all at the same time. The other thing is we can stage lymph nodes, okay? This is really important. This person here on this PET scan has a lymph node that's lighting up. Could be lighting up because it's cancer, could be lighting up because it's inflamed. But if this is involved with cancer, that's taken a small cancer here from a stage 1 to a stage 3. And the way we approach treatment for these different stages is vastly different. So it is important that we are able to stage these areas as well. So this is our robotic bronchoscopy platform. It's, like I said, it's a tremendous improvement over what we've had before. We've had bronchoscopy available since the 1970s, but we were only able to biopsy those really, really large tumors. We really couldn't get to the small stage 1, stage 2 cancers. In 2014, we started using electromagnetic navigational bronchoscopy, which was much better than what we had before, but we were still somewhat limited. Earlier this year, we got the Ion robot, and now we're able to get even smaller nodules. Basically, what this allows us to do is we get a CT of the patient, we plug it into this software, and the computer basically creates an airway tree, a virtual airway tree, and it locates the nodule in relationship to the tree, and it will automatically find a pathway through this tree to get to that cancer. We control it with this console. On the left, we have a scroll wheel that moves our catheter forwards and backwards. We have a scroll ball that will rotate it or flex it. And as you can see, it flexes quite a bit, 180 degrees. And this catheter is so small and it's so maneuverable that it allows us to get to these areas that we weren't able to get to before. So this is our device here. You can see the robot with the catheter going into the mouth through an endotracheal tube. We control it here. We have a screen where we watch where we're going as we're driving through. And this is an example of a patient that I did a bronchoscopy on a few months ago, actually maybe 6 weeks ago. She was 75 years old. She had smoked for 48 years. She had a normal screening CT last year, but this year she was found to have this 9mm nodule. And we plugged her into our software. We located the nodule here in the right upper lobe. The computer gave us a pathway to get there. So this is what we're seeing when we're doing the planning. The computer is basically telling us we're going into the right upper lobe, we're going to follow this path, and it tells us where we go and how we get to that nodule. Now this is an actual procedure. I didn't do this, my partner did this, he recorded this. So it shows the actual image, what we're seeing with the actual bronchoscope, and we're following this virtual pathway to get to this nodule in the left upper lobe. So you can see that we're just basically following the virtual pathway. It's like GPS to get to where we need to go. And you can see that the virtual airway looks almost exactly like the real airway. And I think this doesn't go quite all the way, but you kind of get the idea. And what I want to show here is we actually use what's called fluoroscopy. So when we get to where we want to get to, we can actually take X-ray images as our instruments are going out so we can see in real time what our instruments are doing. So you can see that we're pointed right at the target. This is the target here. And you can see down here, we're sticking a radial ultrasound probe so that when we get to that target, we get a signal. And that signal shows us that we actually are where we're supposed to be. So I wanted to end with this slide. About a year ago, the American Lung Association came out with this report, which looked at what percentage of eligible people in the United States who can be screened are actually getting screened. And unfortunately, the results were quite poor. Only about 5.8% of eligible Americans were being screened. And when my friend and colleague, Dr. Clark Fuller, told me that California ranked last in the country, I didn't believe him. Because I see patients all the time that get referred to me for abnormal screening CTs, but in fact, only 1% of Californians who are eligible for screening are getting screened. So I like to look at the glass half full. To me, this is an opportunity. So I think we need to do a better job. There's certainly room for improvement, and I would urge all of you, if you have friends or family who are smokers or former smokers, tell them about it, because a lot of people don't know about this, and we really can do a lot more to cure lung cancer. All right, so I'll end there. Thank you very much.
Thank you, Dr. Abe. And we'll go ahead and move on to Leena Tran.
Thank you. All right. Good evening, everyone. I'm excited to present to you today on this topic of cancer genetics. And so I know that the focus of the talks today so far have been on cancer early detection and as well as cancer prevention. So my goal is to provide some backgrounds on how genetics is also an important part of potentially detecting cancer early or even preventing cancer. But before I dive into genetics specifically, I wanted just to preface again that cancer is a very complex condition, and by existing on this earth, all of us have a risk for something. But the question is, how high might that risk be, and what's impacting your risks, whether it's genetics or other factors? So as you can see here in this diagram, a person's personal level of cancer risk is defined by many different things. Genetics at the very bottom is only one of them, but it also includes things such as the environment, your lifestyle, random chance sometimes, your family history, as well as aging. So for the rest of the talk today, again, I'll focus a bit on that genetics aspect. But before I dive into more information about that, I just wanted to explain a little bit more about cancer and the hereditary components in general. As you can see here in this pie chart, only about 10% of cancer is considered hereditary. And what it means for cancer to be hereditary is that perhaps we draw some blood and look at your DNA and found that you were born with a genetic change that increased your risk for cancer and maybe explains why you developed that cancer. The rest of the time, as you can see, a large part of it is more sporadic in the gray. About 65% of the time, we don't know why someone developed cancer. And maybe it's a combination of those other factors that are not genetic, but a genetic test such as the ones that I might do will not give us that answer. So again, today we'll focus on that minority of cancers in that 10% category that are considered hereditary. And so how might you find out if you are at risk for a hereditary cancer? This is where genetic counselors such as myself come into play. So there are a lot of genetic counselors out there specializing in various specialties, but mine is cancer. And per the national society that we belong to, you can see here that we have advanced training in genetics, but also counseling, because our goal is to help you and your family navigate this process that is genetic counseling and genetic testing. And a large part of it is providing you education on how conditions like cancer can be hereditary or inherited, how it might impact you and your family, and also how to move forward based off of that. If we do find out that you have this genetic risk, what should we do to help detect cancer early or prevent it altogether? So with that, I wanted to review some of the most common cancer conditions that I see in my clinic. So here, some of you in the room maybe have heard of the BRCA genes. So BRCA1 and 2, or BRCA1 and 2, or if you've heard about Angelina Jolie many years ago, getting tested for this and finding that she was positive, as an example. So genes such as BRCA1 and BRCA2 are things that we all have. It's actually a misconception when someone asks you, hey, do you have the gene that makes you more at risk? We all have these genes. They normally function to protect you from developing cancer. But it's a question of whether you were born, again, with that genetic change or what we call a mutation that impacts the ability of your gene to now protect you from cancer. So as we talk a bit about mutations, when I think about breast cancer and ovarian cancer specifically, they're most commonly associated with BRCA1 and BRCA2 mutations. And what we also know is that these are more common than we might think. In the general population, about 1 in 400 people have a BRCA1 or a BRCA2 mutation that might make them at higher risk for breast and ovarian cancer. And this is also one of the areas where someone's ancestry might also be important. We mentioned that in the general population, about 1 in 400 people might carry such a mutation. But if you are Ashkenazi Jewish, 1 in 40 actually carry this. So certainly, if you have ever had a strong personal and family history of, say, breast or ovarian cancer and have not had genetic testing, I would talk to your doctor if you're interested and see if you can get referred for genetic counseling and testing, potentially for you and your family. So this is just one condition that I work with, but I know we've talked a little bit today already about colon cancer. So I want to touch upon a condition related to that. So this diagram here shows you some information about another condition called Lynch syndrome. Lynch syndrome is associated with the combination of different cancers, most commonly though, hereditary colon as well as endometrial cancer. Earlier, we mentioned that BRCA mutations are common. It's also the same for Lynch syndrome. About 1 in 300 people in the United States alone have Lynch syndrome. And many people don't know that. You wouldn't know. It's not something we can just take a look at you and guess that you might have this. But if you have had, again, a strong or strong family or personal history of colon cancer or uterine cancer and maybe some of the others seen in this figure, again, another reason if you're interested to consider genetic testing. But now you might ask, well, what do I do with that information? Again, if I find out I have a BRCA mutation or Lynch syndrome, where do I go from there? So the first part is that it can impact your care, but also the care of your family. So once someone is found to have one of these conditions, I help them develop that next plan in terms of how do we, again, find cancer early if it occurs or prevent it altogether. So this can include recommending additional cancer screening. So as kind of a standard, most women are starting mammograms at the age of 40 and doing it on an annual basis if they don't have other risk factors potentially. But if they were found to have a BRCA mutation, again, and are at higher risk for breast cancer, they might also benefit from having breast MRI. And so you get imaged with both mammograms and breast MRI, alternating the two every 6 months with the goal of catching something as early as possible. And this can also apply to other screenings. So going back to Lynch syndrome, if someone knows that they are at a higher risk for colon cancer, instead of waiting until they're 45, kind of the general age we start, they might start earlier, say even 30 years old. And instead of doing it maybe somewhere in the range of 5 to 10 years, such as what a lot of people generally do, maybe you're doing it every 1 to 3 years. Again, the goal, trying to find any of those precancerous polyps. If they develop, remove them before they turn into a cancer. And lastly, there are other preventative options that a person might consider. So if there's a higher risk for, say, uterine cancer, we might consider a hysterectomy to remove the uterus, or something called a salpingo-oophorectomy that removes the ovaries and the fallopian tubes at certain ages. Some women, if at a higher risk for breast cancer, you might have heard, have had preventative surgery like a bilateral mastectomy to remove breast tissue and again, reduce that risk. And lastly, depending on the types of cancers, we can consider potential medications to also lower some of the risk as well. And so I mentioned that this is a big process, not only for you, but also your family, because there is an impact on them as well. So say you go through testing, or someone else in your family goes through testing and finds out that they have a genetic mutation. All of their first-degree relatives, so that includes their parents, their siblings, their children, have a 50% chance, or a 1 in 2 chance of carrying that same mutation. So oftentimes when a patient is found to carry one of these, I will encourage them to share that with their family, so their family can also find out if they are at risk and might want to consider those options we went over before. And so I see a lot of relatives in my practice as well, and help them through their own genetic testing, and again, help them with their care plan moving forward. But all of this, certainly comes with its own psychological impacts. So patients have reported both positive and, some not so positive impacts on their mental health and maybe their emotional well-being. And in the moment, some patients come to me and they feel very interested and they're very relieved, to find some more information about their risk and potentially their family's risk. And they feel very empowered, right, by getting this information that they can now use to inform screening and early detection as well as prevention. There are some also, by receiving these results might feel sad or a little upset or anxious or even guilty, given the inherited nature of these mutations. But that being said, I have seen over time that most patients, if they feel this, it's more of a temporary feeling. And over time, the benefits of it, as we've been mentioning here, really outweigh some of the momentary negative feelings that someone might feel. And with all of that, certainly I mentioned today that I highly recommend seeing a genetic counselor if anyone is at all interested in talking about your history and your family history and potentially genetic testing. So we have great genetic counselors all over the South Bay and in the Southern California area, and such as I myself here see patients at the Hunt Cancer Center. We have other colleagues in this area as well, but if any of your family members needed genetic testing and say they live out of state or much further away, we have a great directory from our National Society if anyone wanted to ever look up how can I find a genetic counselor near me based off of where I live. And that's it. So I'll take some questions during the Q&A later.
Thank you very much, Leena. And again, last but not least, I want to introduce Marissa Minderler. Okay, she's going to talk to us about diet and nutrition. Thank you.
Microphone okay? Good? Excellent. All right. Good evening, everyone. Like I said, my name is Marissa Minderler. I know my last name can be a mouthful. It's okay. And I am going to close out today talking about nutrition for cancer prevention. So we heard a lot of really important information about screening, genetic counseling, things that you can do. And now we're going to really hit the nail on the head here and jump into what we can really take charge of for our own health with nutrition. So the things that we're going to discuss today, I'm going to just touch briefly on the role of nutrition in cancer prevention. I'm going to go through the American Institute for Cancer Research, which is the AICR's 10 tips for cancer prevention, okay? And then I'm gonna dig a little bit deeper into the ones that are clearly nutrition related. So what role does nutrition play? Well, it's pretty profound, right? So there's a statistic, from the AICR that says approximately 40% of all cancers can be prevented. Now that's a pretty astounding number, right? And now, of course, this requires the stars to align in a variety of different settings. Getting your screenings done, right? Maybe potentially getting your genetic counseling. But we know that diet and lifestyle have a very strong influence on the role of prevention. So research has really shown a lot of light in the role that this is gonna play. So 7 out of the 10 tips that they discuss are directly correlated to diet and lifestyle choices, okay, and directly connected to the food that we put in our mouth every single day. So these are the 10 tips. We're gonna go into 8 of them. I'm not gonna touch on the last 2, but we are going to talk about the first 8. Okay. So the first one is be a healthy weight. Now this one, of course we wish we could just snap our fingers, right, and just be a healthy weight, right? But we know that it's a little bit more complicated than that. It's a little bit not as simple to do. But we know that body weight is a result of nutritional intake, physical activity and exercise, stress, of course, environment, genetics, right? Our body weight is affected by many, many things. But there are things that we can do to try to become and reach a healthy weight, okay? We really recommend a whole food diet, okay? Eating foods that are as close to their natural form as possible, right? We want to emphasize fiber. I'm gonna hit that a little bit harder a little later, but emphasizing fiber intake, okay? This is gonna be key. We want everybody to meet the exercise guidelines, as we're gonna talk about next. And then we would like to reduce stress, right? That's much easier said than done. Just don't be stressed out, right? Snap our fingers, don't be stressed out. So these are some of the 4 things that, are the pillars, I would say, of reaching a healthy weight. So being physically active, I love this. My background was in kinesiology, I was an athlete as well. So being physically active is important. Doesn't matter how old you are, okay? Doesn't matter young or old, you have to exercise. Okay, does anybody know the American Heart Association's recommendations for exercise? We'll talk about this in minutes per week. Does anybody know? Feel free to shout it out. We see 60, I think I heard 150. Ding, 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 ding. Yes, 150 minutes per week, okay? But it's also important to hit the intensity, okay? So moderate to vigorous intensity, all right? That means that you're huffing and puffing, okay? For the 150 minutes per week. So depending on your schedule, right? You can do this in maybe 50 minutes, 3 times a week, or you can split it up and do 40 minutes 4 times a week. Or if you'd rather do 30 minutes 5 times per week, either way, you want to make it attainable, right? So 150 minutes. If you can meet these guidelines, it'll also help you be a healthy weight. This is my favorite slide, so I'm going to spend a lot of time on this one, okay? Eat a diet rich in whole grains, beans, vegetables, and fruit, okay? Dr. Bhayani hit this pretty hard, the importance of a plant-forward diet, right, for reducing our risk of colorectal cancer. But we know that this, in general, a plant-forward diet can be beneficial for reducing risk of all cancers, okay? And why is that? Well, we have antioxidants that are found in whole grains, beans, vegetables, and fruits. We have fiber, and we have vitamins and minerals, okay? So antioxidants prevent damage to our cells, right? They are anti-carcinogenic, okay? These really long, complicated words up there. Lutein, lycopene, beta-carotene, allium, anthocyanins, isoflavones, catechins. These are all different compounds that you can find in the color of your fruits and vegetables, okay? So really, really important, okay? Isoflavones are also found in soy, okay? Catechins are found in beans, okay? So these are really important components to make sure that you get into your diet. Fiber, okay? Fiber, as Dr. Bhayani might have mentioned, right? It reduces our risk of colon cancer. Heart disease, constipation, right? We gotta be regular, okay? We gotta be regular, right? And a lot of people are struggling with increased cholesterol, okay? So fiber helps reduce your cholesterol, okay? It also feeds our gut bacteria. So we've heard this term gut health, right? Everybody's obsessed with gut health, right? Well, fiber is the food of your healthy bacteria, okay? So the more fiber that you can take in your diet, the more you're gonna feed those good microbes, and this is gonna help promote positive gut health, okay? It also assists with weight management, okay? Foods like whole grains, beans, vegetables, and fruits, they're called volumetric foods, right? They take up a lot of space in our stomach, okay? So that actually helps us feel full and feel satiated more, and that can assist with our weight management. Vitamins and minerals, okay? A lot of supplement companies are gonna convince you that you should take a bunch of pills to get your vitamin A, your vitamin B, your vitamin C. You don't need to do that, okay? You can get this through food, through a balanced diet, okay? If you eat these whole grains, beans, vegetables, and fruit, you can get as much as you need of all of these nutrients. All right, even though it looks delicious, we got a limit, right? And it looks yummy, right? And we have to limit our fast foods and our ultra-processed foods, okay? And this is because these types of foods are very high in fat, they're fried, right? They're likely to have trans fats, okay? Which are likely to increase our risk of atherosclerosis, heart disease, okay? And then a lot of these foods are also high in simple sugars, okay? Simple sugars being like sodas, right? Donuts, right? These are going to potentially increase inflammation through and possibly increase our production of insulin, right? We know that that can increase our risk of getting diabetes, right? So we really want to try and limit these fast foods and processed foods. Red meat, okay? Red meat and processed meat, we have to try to limit or avoid, okay? Now this is a little bit of a difficult topic because the portions that people say, like, well, what is enough? What is too much? What's the right amount? The answer is it's hard to know exactly. Again, we know that for somebody, maybe 3 ounces is gonna be enough, or too much, I should say. 16 ounces might be enough. You know, we really don't know. But generally speaking, okay, if you consume red meat, the AICR says no more than 12 to 16 ounces per week. I think that is a little bit on the higher end. Okay, I think that's kind of a gracious amount. Much research suggests that if you choose red meat, you should have less than 3 ounces per month. Okay, per month. I know, it's hard to think about, right? The 3 ounces for most people is about the size of your palm, right? They're recommending that for less than 3 ounces per month. Okay, so something to think about. Sweet drinks, sweet teas, sodas, frappuccinos, coffee beverages, the Starbucks eggnog, gingerbread, mocha, caramel, frap latte thing, whatever they have, right? But we know that sweetened drinks, right, as I mentioned, can give us a lot of sugar, right? And too much sugar, excess sugar is not ideal for us. It can lead to excess weight gain. It can stimulate too much insulin. It can increase your risk of diabetes, okay? Does anybody know how much a grande mocha frappuccino is at Starbucks? How much sugar? Just throw out a random guess. 40 grams. We hear 40 grams? 80 grams. 80 grams? 51. So we're almost there. Okay, 51 grams of sugar. Does anybody know the daily recommendation for sugar intake? Less than that, yeah, for sure. It is less than 24 grams of added sugar per day. Okay, so you're getting double that in just one drink. Okay, so something to think about. So simple swaps, right? Fruit infused water. We have a lovely, lovely table over there with fruit infused water, right? So that's a great way to just try to hydrate, but still get a little bit of extra flavor in there. You can try unsweetened teas, right? Those are great to drink. Or you can even dilute lemonade, okay? So just keep in mind that some of these sweetened drinks, right, are gonna have 25 to 70 grams of sugar, depending on their serving size. Okay, so try and swap for water or any of those other diluted beverages we talked about. Alcohol, okay? Alcohol is a difficult topic for some people, but generally speaking, when it comes to cancer prevention, less is more, okay? If you choose to drink, okay, we recommend that you stick to a standard drink, okay? So 1 standard drink for women, 2 standard drinks for men. I still think it should be 1 and 1, but they say one for women, 2 for men. So what is a standard drink? Typically, these are not what we are served in restaurants, anywhere that you go out, right? So a standard drink for wine is 5 ounces. You typically get 6 or 9 ounce pours, right? A standard drink for beer is 12 ounces. You typically get a pint, which is 16. And then a standard drink for hard liquor would be 1 shot, right? Or 1.5 ounces. They typically give you 1.5 to 2, right? So generally speaking, we say try to stick to a standard drink if you can. Supplements, last but certainly not least, okay? We recommend that you do not rely on supplements unless directed by one of us, a registered dietitian, or perhaps your physician, okay? But generally speaking, supplements are not regulated at all, okay? They are not regulated like food. They are not tested like prescription medications. They don't go through a rigorous process. I can go into my backyard, scoop up some dirt, put it in a pill, and tell you it's vitamin C. No regulation whatsoever, okay? So it's actually estimated that 10 to 30% of all supplements can contain adulterated substances, okay? And then 89% of supplements do not contain what is listed on the label, okay? That's pretty big, right? So it's really important if you do purchase supplements to check if they are third-party tested, but most of what we can get can be gotten through food, okay? Also, supplements are very expensive. Some people spend upwards of $60 to $150 a month just on pills that they may not even know work, okay? So if it's, and a lot of these supplements are making these unfounded claims, right? So if it sounds too good to be true, it probably is, okay? So I definitely recommend focus your energy and effort on food. So if you have questions, or if you are interested in, scheduling an appointment with us dietitians, these are some of our information. And I hope that this was helpful. Hope you guys will take charge of your health regardless of your age. And our speakers today were great. So I hope that everything has resonated with you, okay? Thank you guys for your time.
Thanks very much. I think we're going to take a minute or two for you guys to collect your thoughts and write down some questions, and then we'll have a Q&A session. There you go. Perfect. And I'm going to get a drink. Non-alcoholic. For a few seconds, and then we'll get started. Okay, so in no particular order, so one frequent question was, what about vaping and lung cancer risk? What do we know about that?
Oh, is it on? Okay. So vaping is kind of an unknown. We don't really know what the long-term effects of vaping are on lung health. The presumption is that it's less likely to cause cancer because all those carcinogens that are in tobacco smoke are found in very, very minute quantities in the vaping liquid. So in that sense, it probably is less carcinogenic than tobacco smoke. In fact, for sure, it's less carcinogenic. But again, we don't know the long-term effects. And as I was just saying, it's not regulated well. There's all different companies out there putting out products. They've tested some of these products and have found trace metals, things like arsenic and nickel and cobalt and things like that in it. So you don't know what you're getting. So
yeah.
For a lot of reasons, if a patient came to me and said, hey, I started vaping and I'm not smoking anymore, I wouldn't say go back to smoking. I would say, look, vaping is probably better than smoking, but we don't know the long-term effects, and I would really prefer that you try to eventually get off of it.
The other thing I would add is that there have been occasional outbreaks of severe acute lung injury related to vaping, which you won't see with tobacco. A young person comes in with acute, essentially failure of their lungs after vaping, like Dr. Abe said, who knows what, because it's not very regulated. We don't see it that much anymore, but there were quite a few cases in the very beginning, I remember. Okay, another question. What about the color of my stool? Does it matter? What do I do about it? What if it changes? What if it's light or dark? What do I do? I think that might be yours, Dr. Bhayani.
Yeah, so the color of your stool should vary normally with what you're eating. You know, everybody knows what happens when you eat beets, right? So, sorry, can you hear me better? Okay. Yeah, so the color of your stool really should vary on a normal day-to-day basis. There are foods that are definitely going to change the color of your stool. There's really no bad color to your stool, but if you do notice either bright red, which is indicative of blood, or a dark, tarry, sticky stool, those are some things that you want to bring to the attention of your doctor pretty quickly.
Yeah. And the other thing that you mentioned was that if you notice a change in the size of your stool over time, it's something that's persistent. That would be another thing, right? Right. Okay, I'm going to throw in a question. What about the frequency of colon cancer screening? Based on having a negative colonoscopy or seeing a polyp or family history, how does that alter that?
Yeah, so the current recommendations got updated just a few years ago. Starting at the age of 45 is when an average risk person. So how often you have screening is based on your personal risk factors, your family history and genetics, as well as your lifestyle, and then of course what they find when they go looking. So an average risk person should start at 45. I'll pass it to Leena for a second for some of the special populations. But an average risk person should start at 45. If you're clean, if you don't have anything, on a colonoscopy, you can go 10 years. But the less accurate tests, whether it's a CT scan or the blood testing cards or the FIT testing, you have to do it more frequently because it's less accurate. And then of course, if they find something on the colonoscopy, they're gonna do things more frequently to make sure you're not somebody that's prone to polyps and cancer. But for special populations, we do screen more aggressively.
Yes, as Dr. Riano is saying, the recommendations are different for our more high-risk populations. So if you recall, if people who have Lynch syndrome, as an example, and they're at higher risk for colon cancer, some of them, depending on their level of risk, might start colonoscopies as early as their 20s even, instead of waiting until 45, like Dr. Bhayani was saying. So that's a significant difference. And they might often have it a lot more frequently, even as frequent as 1 to 3 years, even if, say, their last colonoscopy was normal. No polyps or any concerning findings, just the level of risk that we know is going to prompt them to come back in 1 to 3 years, instead of average risk person, say again, their colonoscopy is completely normal, no polyps, they might have a much longer window before they come back again. And actually, I've seen some of the commercials for like Cologuard on TV as an example, and it actually even mentions in the disclaimers in very fine print, if you have a hereditary condition like Lynch syndrome, we don't recommend that you have stool-based testing based off of, again, kind of the limitations, and the gold standard for people who are at higher risk are colonoscopies, as we've been saying.
You should keep the microphone because this one's for you too. What is the difference between hereditary and familial when it comes to cancer genetic testing?
Yes, so familial is also a complex category in that pie chart I showed earlier. About kind of a quarter of cases are not quite sporadic, but not quite hereditary, and they're instead familial. So there are many families that I've seen where you see a pattern of cancer, but we cannot find a hereditary cause. We do a big genetic test all the genes we know related to, say, breast cancer, and we do not find out the explanation for that family history of breast cancer. It does not mean that the person in the family who, say, doesn't have breast cancer yet has a zero risk. They still have this pattern in their family. And when things are familial, it's because there maybe might there might be smaller genetic contributions that we don't know of and can't test for yet, so it's not quite the hereditary category. But also we have to think that families share other things besides their genes. They share their environments. So maybe if there's certain chemicals they're being exposed to where they're living, as an example, that could be something that's shaping their family history, or maybe they share similar lifestyles or other risk factors. So this familial category is made up of a lot of other things too that families can share besides their genes.
Thank you. What is the best nutrition for a cancer patient?
That's actually a very complex question. It depends certainly on where your starting point when you begin treatment. It depends on your goals of treatment. Generally speaking, we recommend to maintain your weight throughout treatment. Anything as much as 2% loss of body weight can be associated with poor outcomes. So we don't necessarily recommend weight loss throughout treatment. Now, of course, if someone has a much higher percentage of body fat, right, then some weight loss might be okay, may not necessarily impact treatment outcomes. But nutrition specifically through treatment is more complex. We usually take it day by day, especially because your food intake, your tolerance, your appetite, your many things can change day by day going through treatment. So there's no such thing as a best nutrition. It's definitely just individual for sure. But if you can follow the guidelines that we talked about today, the 7 tips that were nutrition related, those will also be helpful throughout treatment. Physical activity also is actually highly recommended throughout treatment. There's been shown to have a lot of positive outcomes associated with more physical activity during treatment, but we know that that's also very complicated and very difficult. When you're going through chemotherapy or radiation, there can be complications. So nutrition-wise, I would just say, in short, follow what we just talked about.
Excellent. What about lung cancer screening for that proportion of lung cancer patients or persons that don't have a risk factor? So you said 20% of lung cancer cases are non-smokers. Are there recommendations for screening that population?
Yeah, there are no screening recommendations for people who have never smoked. They're doing some studies on that. There are populations of people, for instance, Asian women are at much higher risk for adenocarcinoma of the lung because there's a higher incidence of a mutation called EGFR. I'll see patients where I'll have a woman who's in her 40s who has a mother, an aunt, and a sister who all have lung cancer and never smoked. Right now, the guidelines don't allow for that, but we will likely have some studies at some point that will shed some light on that. There will always be people who fall outside the guidelines who you're going to know are at high risk because of the family history and things that we can't really identify. And I think you just have to try to work your way around that. But right now, if you're a non-smoker, the guidelines do not recommend any screening.
And one follow-up question, does insurance cover early screening for smokers, say in age 50 to 60?
Well, yes, if you're age 50 and you have a 20-pack year history of smoking and you either are a current smoker or have quit within 15 years, then yes, you are eligible.
Okay, another cancer screening question, this one for Dr. Bhayani, I think. Is there an age when you can forego further colon cancer testing if you have had a prior polyp?
Yeah, I think this is a great question. The short answer is if something else is going to kill you before your colon cancer, then you don't need a colonoscopy. And that's really, I think, a very individual thing. I see in my office a lot of healthy 80-year-olds, believe it or not, coming in with something else. And so if you're healthy and you're 80, even though the guidelines suggest you don't need to be screened, if you're healthy and you're 80, you're probably going to make it to 85 or 87 or 90, or in my grandfather's case, 98, and he's still kicking. And so you don't want colon cancer to be the thing that takes you down at that point. So it's individual, but if you're healthy enough that screening is going to benefit you, then I think it's worthwhile.
Got it. And follow another question. Does diverticulitis set you up for cancer?
Thankfully, no. Diverticulitis and diverticulosis is much higher in Western countries where we have a protein-heavy and a fiber-light diet. I'm going to set up a colleague to T-bone or to follow up on that one. But diverticulitis does not set us up for a cancer risk.
Yeah.
Yeah, so diverticulosis, right, is the specific condition where you have the perforations or the pockets, so to speak, in your colon, and diverticulitis is when something inflames those pockets, right? And more research now shows that those perforations can happen as a result of a low fiber diet. So if you're having to strain to go to the bathroom, having to, push really hard to have anything come out, that increases internal pressure, and that can cause some of those pockets, right? They don't necessarily know exactly when this starts. It could be, I guess, as early as teens, I would expect, but maybe in your 20s as well. But the idea is that fiber is actually protective against diverticulitis, so the inflammation of those pockets, because it helps increase pressure, increase stool volume, which actually helps you poop more efficiently. So fiber deficiency is actually not a good thing if you have diverticulosis. So a while ago, the recommendation said to avoid certain foods, popcorn, corn, seeds, things that could get stuck. But technically, if you're eating enough fiber as a whole, nothing will get stuck. So
You're getting all the glamorous questions. What food would you recommend that we avoid apart from red meat? Can't use red meat again.
yeah. So contrary to what you might think, I actually do not recommend you avoid any food. Okay, I don't believe anything should exist outside of what you can intake. Now, of course, the amount of things and your exposure over time of all of these things, right, can impact. No, I would not necessarily recommend that you have a soda every single day, right? But if you have a soda here and there, it's probably not going to be a huge problem, right? But no single food exists in isolation of causing problems, right? You have to think about an overall dietary pattern, right? A soda or a bag of chips or a piece of candy can fit into a healthy diet if you exercise, if you eat whole grains and vegetables and fruits for most of your diet, right? If you avoid some of the other processed foods, right? So no single meal is going to ruin your health. No single food is going to ruin your health. But of course, you think about it with an overall dietary pattern. So you have to have those other things to balance it out.
All things in moderation. Is there a type of genetic screening you would not recommend someone undergo?
That is an interesting question, and perhaps kind of a loaded question. So as part of genetic counseling, what I often do is, again, take a risk assessment based off of someone's personal family history and really walk them through the most appropriate options for testing based off of their, again, personal or family history. And a large part of it is seeing, what is most appropriate, and also seeing based off of how they're feeling at that moment. Are they feeling ready to do this right now? Do they need some more time? Those are some of the things that I kind of gauge for to see should someone have this test or not. I just thought of some tests that maybe people have also heard of. As an example, there are some what we call direct-to-consumer genetic testing. If you've ever heard of companies like 23andMe as an example. I think most people utilize 23andMe to find out maybe some interesting information like their, their ancestry or other random traits such as, if I eat cilantro, is it gonna taste soapy or not based off of my genetics? One thing I want to mention is that if someone uses direct-to-consumer testing to maybe find out a little bit about their genetics in relation to their health, I'd advise people to be cautious of the limitations. So as an example, historically, 23andMe has offered some testing for the BRCA1 and BRCA2 genes, which I mentioned earlier. Again, those are very common in the population for someone to have a mutation, but historically, 23andMe has only tested for 3 of the thousands of possible mutations that exist within those 2 genes. So we've had people who maybe get some false reassurance, which I think is potentially dangerous, if they do a very limited test such as that is not clinical. So ultimately, the testing that I recommend is clinical genetic testing that is coordinated by a physician or perhaps a genetic counselor such as myself. I think that is kind of the gold standard, similar to the way that we've been talking about like stool testing in comparison to colonoscopies. Like there's gold standards for these things, including genetic testing.
Thank you. Okay, we're going to group these 2 questions together. How bad is stage 1 colon cancer, and what are my treatment options for colon cancer? Not necessarily just stage 1.
Sure. So stage 1 colon cancer cure rates are well over 95%. So when you find colon cancer early and it's treated effectively, which is surgical, there's no further treatment required, and your chance of cure and living a normal life is exceptionally high. For any stage of colon cancer, we have 3 reliable options for treatment: surgery, chemotherapy, and radiation. And unfortunately, we'd like a less invasive or less toxic treatment, but truth be told, these are the only proven 3 modalities for treating any cancer. And so, again, each patient is different and each cancer is different, and we try to figure out what is the right combination or modality, but those are the treatment options for colon cancer kind of writ large.
Great. This is for Marissa. What are your thoughts about probiotics?
Yeah, so probiotics exist in foods, right? So yogurts, kefir is another type of dairy-based that has probiotics. So basically cultured foods, right? Sauerkraut, kimchi, those are actually fermented foods that are not technically cultured, but they get lumped into kind of the probiotics, right? So they are technically things that your good bacteria can feed off of. Sourdough bread is actually probiotic, it's cultured, right? So probiotics are anything that is cultured, okay? Again, supplement companies have convinced you that pocketing it and putting it into a capsule is gonna be beneficial for your health, but research hasn't quite caught up with it yet. We don't know even the number of strains that you need to have it be optimal for health, but so if you're looking to have probiotics, I recommend you get it through food. There are plenty of options. Natto is another type of food that is cultured. That's more popular in the Japanese culture. So many different options that exist for getting all of this through food. But I would definitely recommend, proceed with caution with the supplement-based probiotics, because once again, they are very expensive, and the research is not necessarily caught up yet on their efficacy for individuals.
One other for you. I think someone is really trying to rescue a favorite drink here. I've heard that cherry juice is anti-inflammatory. Would you consider tart cherry juice a sweet drink?
So any juice, right, from fruit is going to have sugar, right? But it also has the color, right, the antioxidants. There's actually a ton of evidence that shows tart cherry juice is actually an antioxidant. It actually has antioxidant properties. So we actually recommend athletes take that for recovery. Tart cherry juice even has a little bit of melatonin in it, so it actually can help with some sleep. So football players, soccer players, and any athlete, actually, we tell them to consume tart cherry juice after exercise to help reduce inflammation. So yeah.
I'm looking for your disclosure form here. I can't really find it. Are you a shareholder in a tart cherry juice company?
I have not mentioned any companies. Okay. No paid partnerships.
Okay. I'm supposed to increase my iron intake and take a supplement. What can I eat to get as much extra iron as possible? I would guess that red meat is out.
Technically, no. Red meat is, yes, a form of a bioavailable form of iron. But I think of the B's. So beef, beets, and beans. All right. So beef, beets, and beans. Beets are very high in iron. So plant sources of iron are less bioavailable. So we tend to have to eat a little bit more of them. So again, pushing a plant forward diet, eating a lot of beans and beets if you like that. But iron is also best absorbed with vitamin C, source of vitamin C. So if you eat more plants, you can add a little bit of vitamin C. So lemon juice, lime juice, squirt that on top of your beans or something, and you can increase your absorption of iron. But yeah, technically, like I said, you can still have beef, of course. We don't necessarily recommend that you have to completely cut it out.
Although 3 ounces a week probably isn't going to get you enough iron.
Yeah.
Right. Okay. How long after someone quits smoking does their lung cancer risk return to normal?
So the bottom line is actually never. It does go down for quite dramatically or quite significantly for the first 15 years. But even after 15 years of abstinence, you're still going to be at higher risk than someone who never smoked. The reason why they designed the National Lung Screening Trial to include people that had quit smoking within 15 years was for that reason.
Okay. And then finally, this is kind of a very broad and complex question, but I think it's a good one. What is the goal for treating lung and colon cancer?
Cure. You have any thoughts?
Well, I guess just to nuance that, is there ever a goal other than cure? Do we treat people where we know we can't cure them?
Of course. So there are people that can present with, relatively advanced, cancer, lung cancer, stage 3, and with the types of treatment modalities that we have now, can have quite a long survival. And this is especially true if they have a gene mutation where we have targeted therapies for those mutations. People can do exceptionally well with that. And I'm sure you've always also heard about immunotherapy. So if you have a abnormality that would suggest that you would be someone who would benefit from an immunotherapy, people can also respond very well to those as well. So yes, I shouldn't say just cure, but the ability to prolong someone's survival and give them quality of life is also a goal.
Yeah, I think without being cheesy, when I sit down with someone at an individual basis to talk about their colon cancer or pancreatic cancer or whatever it is, my goal is whatever their goal is. There are people who want to shoot for the moon, and no matter what it takes, they're going to fight for every last second with their child or their grandchild or their loved ones. There are people that want to run one more marathon. There are people that want to dance at their grandkids' bar mitzvah. Without being cheesy, it's based on the person in front of me and what they want to do and what they want out of it.
Great. I have no further questions on paper. Does the audience have any further questions for right now? I guess, do you have any questions for each other?
Yeah, I was actually going to tee up my colleague for, nobody asked about artificial sweeteners.
There you go.
That one comes up a lot.
All right, so artificial sweeteners, so these are things like Splenda, Equal, Sweet and Low, those colorful packets, next to your coffee. So those are not inherently dangerous. They have what we call acceptable intake limits, right, of these things, and much of these are 100 packets, 300 packets, 75 packets. Realistically, nobody is going to be consuming these, so your risk of any sort of issue with these is very low when it comes to, I guess I would say, causing cancer. I know there was Something that came out recently, that aspartame may increase your risk of cancer or cause cancer, but that was not really a founded statement. The only thing about artificial sweeteners are they are anywhere from 100 to 600 times the sweetness of actual sugar. So they increase your sugar threshold, right? They make you crave sugar the same. Your body is getting the same signal of something is sweet, right? We don't necessarily, it obviously does not spike your insulin like sugar does, but you are still getting that sensation of sweetness. And so if you are used to putting a packet of Splenda in your 8-ounce cup of coffee, and you decide, you know what, I think I'm just gonna have regular sugar, I'm gonna stop having the artificial sweeteners, and you put a packet of sugar in there, it's gonna taste like nothing. Okay, so that's the inherent challenge, I guess, with the artificial sweeteners.
They also don't do anything for satiety, so you'll still feel just as hungry, right? Yeah. Oh, go ahead.
What about I had radiation for head and neck cancer, so the dryness, the taste, just everything is just sucks. I mean, I should be a string bean, I don't understand, but what about juicing? I have a really hard time with vegetables. Spinach is okay, but it's so bad. What about juicing? Because you can just gulp it. And
So what is your question in regards to, like, is it okay, or?
I mean, if I can't eat much vegetables, then the juice I can just gulp, just get it in, as bad as it tastes.
Yeah, no, I mean, again, nothing is bad, right? We've established that nothing is off limits, nothing is bad, right? You can certainly juice carrots, celery, anything, right? If you do want to try vegetables again, maybe try them in a broth or something that's a little bit softer that has liquid. Some people recommend like having lemon juice and just having some sort of, any sort of liquid, right, with your food to help with that dry mouth. Okay.
Red sauces or all that stuff is
Okay. Yeah. Well, we'd like to see you, I guess, to talk about more solutions. But again, juicing is certainly not necessarily bad.
But will it fill in for not eating the vegetables, I guess?
You will be getting the colors, you'll getting the vitamins and minerals, but you will lose out on the fiber. That's all.
Dr. Bhayani, you mentioned in the slide that the one of the prevention was aspirin for 5 to 10 years. How many milligrams every day, or?
Yeah, that's a good question. They did look at 81 milligrams and 325, and it does seem like the 325 is better, but 81 does help. So it isn't 81 a day is better than nothing, and 325 is better than that.
But also be aware, aspirin will promote your risk of bleeding, and it can also promote things like stomach ulcers and so forth, especially at the higher doses. So it's probably a decision to take it with the advice of your doctor, I would recommend. Yeah. Any other questions? Seems like we've covered a lot of ground tonight.
Good questions.
Okay, great. Let's have a big round of applause for our panel. And thank you for joining.